Welcome to PROCURE Health Talks, a webinar specially designed for men affected by prostate cancer and their loved ones. The various topics covered in these webinars are intended to provide reliable information based on the concerns and questions asked to PROCURE healthcare professionals. Let's begin.
Hello, today as part of PROCURE Health Talks, I have the opportunity to discuss prostate cancer treatment. We're going to discuss specifically active monitoring, surgery, and radiotherapy. My name is Thierry Lebeau. I am a urological surgeon at Maisonneuve-Rosemont Hospital. Here are some classic statements from prostate cancer patients. Can you see yourselves in any of them? I feel no symptom. I'm in good shape. I don't take any medication. I've never heard of anyone around me having this disease. Or I'm too young for this disease. I'm not even 60 years old. In fact, prostate cancer is curable and asymptomatic in more than 95% of cases. When we talk about a localized prostate cancer, there are a few treatment options. Generally speaking, there are in fact 3 of them. Active monitoring, radical surgery, the objective being to remove the prostate, and radiotherapy. The objective for these treatments or these disease management strategies is to ensure optimal survival for the patient. When we talk about watchful waiting, this is for patients for whom we decide to not move on to treatment and not to have very active monitoring. The idea being to not expose patients to side effects of a treatment without the benefits of having had the treatment. One question you may ask is, how do we diagnose prostate cancer? Generally speaking, in 2023, prostate cancer is screened whether due to a specific family context or with an at-risk population. Typically, we start with blood work to dose out PSA levels. This helps to know the relative risk of developing prostate cancer for a given patient. Following that, depending on the PSA level results, we may move on to a prostate biopsy. It is the biopsy itself that will allow us to detect prostate cancer and eventually to move to an appropriate treatment plan. When we carry out a biopsy, we look at the type of cells in this biopsy and how aggressive a potential cancer will be. This will help us to choose for a given patient which treatment will be the best. Under some circumstances, we may use an MRI. This is an imaging the whole prostate along with any spots or lesions that could suggest cancer. This is useful because it helps us to guide any upcoming biopsies and to increase the cancer detection rate and to better target the treatment.
Here's an explanation of what the Gleason score is. Generally, we determine the risk for a patient to develop cancer, so the capacity for the cancer to develop and to become aggressive or metastatic over time. The less aggressive a cancer is, the slower it will progress and the less of an issue it is. The Gleason score is out of 10. It is made up of 2 scores. You see on the left column here, groups 1 to 5. So the closer to 5, the more aggressive the cancer is. You can see on the right-hand side of the screen pictures of cells from grade 1 up to grade 5. You see that the higher the grade, the more chaotic the cells are and the less they look like normal prostate cells. So the more the cells are normal looking, the less aggressive the cancer is. The more chaotic cells are, the more we are worried. We determine the risk for a patient in a function of their Gleason score. Once we determined that there is prostate cancer in some circumstances, we may run additional tests to better understand what the cancer is and how much it is spread. We may use abdominal pelvic scan. This isn't systematic, only for those with intermediate or high risk. Same thing for bone scintigraphy or bone scan. This may be useful, again, same as the MRI, to plan any upcoming treatment. Now, the cancer spread. This is when we examine patients. Very often when we go and have the digital rectal exam, we don't find any spot or lesion. This is the T1 grade. When we feel a bump on the prostate, then we talk about a T2. If the bump is larger, say T2B. This is very useful for clinicians like urologists or radiotherapists, but this categorization is not really useful for patients. This is how we determine the grade of the disease. I mentioned earlier the various risk categories for prostate cancer. In the vast majority of cancers, thankfully, the risk is low or intermediate. What this means is that the progression risk is generally low and the cancer will progress slowly. This allows us to make therapeutic decisions, so deciding which treatment to try for a given patient. And we are rarely rushed to pick a treatment. This is the risk stratification that helps us to determine how aggressive to be with the treatment. If the disease has already progressed to grade 4 or 5, then we have metastases. These are circumstances where, unfortunately, we cannot cure prostate cancer. However, we can mitigate it, and we can slow down its growth significantly. There are several lines of treatment nowadays. So even in a context where we have an advanced illness at diagnosis, the last thing we can do is panic. There's always something we can advise to control the disease significantly. We're talking about several years here, depending again on the patient and their medical context. What are the treatments? For a low-risk situation, one thing that we may want to do is active monitoring. Active monitoring is not a treatment in itself. It means having frequent follow-ups with blood work, physical exams, questionnaires to see if the disease is progressing. Why would we want this type of management strategy? Well, it's because we do not wish to expose the patient to side effects of a treatment if there is no strong benefit to it. We want as much as possible, though, monitor the disease as long as it's indolent. Indolent means that it's there, but its potential to progress and to transform into a metastatic phase or even to cause death, the risk, therefore, is very low. Prostate cancer is very common, and we have a lot of perspective with this disease. Perspective means that we know what we're doing. We know when active monitoring is appropriate. I often tell my patients that we're no cowboys. We do active monitoring frequently in order to ensure that as soon as there's a warning sign, we can intervene and then gain control of the situation again. Another type of disease management is radical prostatectomy. The objective of prostatectomy is always to remove the prostate. We sometimes remove ganglia also. The idea is to remove any cancer cells and therefore to heal from cancer. Sometimes we may choose radiotherapy. We pick radiotherapy depending on the current health condition of a given patient. These choices are very personal. It depends on everyone's medical history. It's difficult to say that there's always one intervention that will be better for a given patient. It really depends. It depends what we're trying to do as far as the treatment plan with our surgeon or radiotherapist. Now, for an intermediate risk situation, as I was showing you earlier, we tend to advise for options that are more active than monitoring itself. Radical prostatectomy, again, or radiotherapy are choice treatments. As one is getting older, the older we get, the less the cancer has time to develop. So it may be the case that we choose active monitoring for older patients, but this is atypical for intermediate risk. Most of the time, we advise for one of the treatment options. When the risk is high, this means that the disease is locally spread with high PSA levels or a high Gleason score, especially aggressive. Under these circumstances, we may choose a treatment, again, that's much more active than just monitoring, either surgery or radiotherapy, coupled or not with hormonal therapy. What do hormones do? They increase sensitivity of prostate tissues to the treatment, making the treatment more effective. Again, we adjust depending on the patient's age, comorbidities, and their capacity to go through surgery. These are the types of parameters that help us to guide patients towards one of these treatment options. So now we discovered treatment options for a localized prostate cancer. Watchful waiting, which is distinct from active monitoring, meaning that with watchful waiting, we don't have any plans of curative treatment. Watchful waiting is something that we use for older patients who have more comorbidities. Active monitoring, as I said, is a management strategy. This includes physical exams, blood work, and regular follow-ups. As soon as there's a warning sign, then we move on to a curative treatment plan. And then we have the two classic treatments, radical surgery and radiotherapy, with the objective of curing the cancer. Active monitoring is really only for low-risk cancers. It's quite rare, in fact, for very low-risk cancers that we use more aggressive treatment options. Why? Again, because we don't want to expose our patients to side effects if the treatment is not significantly beneficial. Apart from very anxious patients, generally speaking, we reassure people when we believe active monitoring would be good enough because we truly think that the risk of the disease progressing is low enough so that we can just use active monitoring. There's always a risk that the disease will progress. Again, we use categories to help guide our decision making. So before moving to active monitoring, we make sure that we looked at all the disease parameters and making sure that we're looking at all relevant criteria to determine whether it's reasonable to do active monitoring. There's always a risk of progression. This is quite rare, exceptional in fact, that the disease will progress so fast that we don't have the time to switch to another management strategy. Again, with radical surgery, the objective is to remove all prostate tissues. This helps us to remove all of the sick cells and to avoid subsequent treatments. Of course, there could be a relapse in follow-ups. This is why we have follow-ups over 5 to 10 years. This allows us to quickly cure the disease and move on to a recovery phase. This is more invasive than radiotherapy. It involves surgery. So there is a time from which we're going to recover our sexual functioning and our urinary functioning as well. Generally speaking, after an acute phase that's 6 to 8 weeks, people have recovered mostly. The objective, again, is to heal from the disease completely. External radiotherapy could be also an option. Sometimes with patients who are older and who are poor surgery candidates, due to characteristics of their biopsy, for instance, we can choose that. Typically, this is a treatment that is non-invasive with lesser pain, which means the surgery happens on D-Day, and from there, we recover. Radiotherapy is given over several weeks. During the treatment phase, there's fatigue that can occur. There's less damage, acute damage to tissues with radiotherapy. However, they are cumulative over time. When we look at quality of life data after 1 year post-surgery or radiotherapy, the recovery or sexual and urinary functioning is very similar, and the quality of life is also very similar. One benefit of radiotherapy, external radiotherapy that is that it allows people to continue their daily activities without the interruption of post-surgery recovery for a few weeks. There will be damage to the tissues, just like it would be the case for surgery. However, damage with radiotherapy is much more gradual and will appear over several months. Again, 1 year post-surgery or radiotherapy, the outcome is extremely similar. This is well documented. External radiotherapy does have some drawbacks. We are not removing the prostate, therefore we cannot have a full picture of the grade. So we can't know how spread out the disease is inside the prostate. This doesn't typically really change the way we manage the disease, but it's a little drawback. Radiotherapy is less invasive and has less impact on daily activities. However, these treatments happen 5 days a week over several weeks, so they are time-consuming. And of course, you have to live near a clinic or center that provides this treatment. I mentioned fatigue and various side effects, short-term and mid-term, that are very similar to the other types of treatments. There can be recurrences. This is true regardless of surgery treatment or radiotherapy treatment. There's always something we can do when we experience recurrence. Generally, when there's a recurrence after radiotherapy, we're no longer a candidate for surgery. The reverse is not true, however. There are some circumstances where we do carry out surgery after radiotherapy, but it is not standard. Now, brachytherapy is a type of radiotherapy. It's a little bit different. We use radioactive implants that we insert into the prostate. The objective being to have localized radiation. This is a one-time treatment. We insert radioactive beads inside the prostate, and these beads will carry out the treatment. Not everyone is a candidate for this type of therapy. We need an appropriate prostate volume, and also we need the disease to not be too aggressive or not too spread out. In some circumstances, it can be an in-between treatment that's very reasonable and satisfying for patients to try. It's done quickly, we recover quickly, there's less damage to surrounding tissues since we're not removing them, there's less incontinence since we're not removing the prostate. That is kind of a valve retaining and containing urine. However, there can be side effects longer term, especially on the way we urinate and also on erections. There are some drawbacks to brachytherapy. Since we're not removing the prostate, again, we can't have a full picture of the pathology. We can't examine the whole prostate as we would with a prostatectomy. I mentioned also that it's not an option for everyone. We need the disease to be quite localized, not too spread out, not too aggressive, and we need a specific prostate volume for the treatment to be effective. If the prostate is too small, we can't implant the radioactive beads, and if the prostate is too large, the treatment will not be effective. Just after treatment, we may have urinary problems that are more severe because there's a lot of acute inflammation in this zone. Typically, these are temporary issues. Now, how do we go on picking a treatment? I often say that there isn't one right answer for everyone. The point is not to find someone for a treatment, it's to find the right treatment for a patient. So what helps us guide our decision-making and pick one therapy over another? First, age will be a factor, and medical status. Typically, it goes hand in hand. A few patients are older but are very healthy, but typically that's not the case. So the older that we get, the more that we have poor results from surgery. Typically, it's extremely rare after 75 years of age to consider surgery. It also depends on the type of cancer. Some cancers are smaller, less aggressive, and it, of course, depends on how we explain things to the patient. When we consider active monitoring, we need to reassure the patient and explain that if this is the best option at the moment, it's really because the cancer is not requiring a management that is more active. Again, it's the type of cancer that will dictate the guidance that we provide to patients. I do believe that clinicians bear a strong responsibility to explain treatment options and to reassure patients. The treatment choice will also depend on urinary and sexual function of the patient before treatment. For some patients, erectile function, for example, is the most important aspect. The treatment will depend on what we can preserve or what outcome we can guarantee. Of course, again, we need to provide full explanations, but for whom someone this is number one priority, then of course we pick the treatment according to this priority, the treatment with the best chances of recovering full sexual function. This also applies to urinary function. If a patient is very unhappy with the way they urinate, maybe they urinate often at night, there is not a lot of pressure, and if we take this patient and use radiotherapy, then for sure, at least acutely, the problem will be aggravated. Any treatment will somewhat impact the way they urinate, but again, it depends what they're willing to go through and what better options we may have. Finally, the last factor is the values of the patients. What I tell my patients is that they are the conductors. I guide them, I provide information, just like I'm doing in the current webinar. I try to give them all the tools that are useful to them for decision making, to have a good idea of what's going on in their prostate, in their medical condition generally, and then the patient can confront that with their actual values. A patient who's well prepared, who picks their own treatment, fully informed, is much less likely to be disappointed than someone that we try to convince. Now, for intermediary risk, as I said earlier, we tend to be more active. So active monitoring is not really an option here. We do pick a treatment, surgery, or radiotherapy. For high-risk cancer, even more so, we'll want to pick a more active or aggressive treatment. We don't want to be watching the disease progress right under our nose. A higher risk case is a case where there's stronger potential to develop remotely, so stronger potential to metastasize and lead to death. When we talk about stronger potential here, thankfully, this is a disease that does not evolve over just a few weeks. In the vast majority of cases with prostate cancer, development is slow enough, but we want to intervene nonetheless promptly to control the disease. Now, what leads us to a specific treatment? We mentioned age, comorbidity factors, symptoms. For a patient less than 65 years of age who is healthy, then generally we recommend surgery if they're a good candidate for that. One benefit of surgery is that if the disease recurs or if we feel that there may be some cancer cells left in the body post-treatment, we can also add on radiotherapy. Prostate cancer is a disease that gives us time to react and adjust. We don't do systematically surgery and radiotherapy together, as is the case with other cancers such as breast cancer. So one benefit of surgery is this, that we can then move on to radiotherapy also. The reverse is, again, not true. For a patient over 75 years of age, the person may or may not be a good candidate to surgery. Typically, we guide people more to radiotherapy because out of experience, we know people tend to have more incontinence. It's difficult to have a specific age threshold and to say from this age on we don't do this or that treatment. It depends. A 70-year-old man who runs marathons is not the same case as a 70-year-old man who has diabetes, who is sedentary, and for whom the risk associated to surgery is drastically different. If the patient has a lot of urinary symptoms, then again, we have to see what these symptoms are, because both surgery and radiotherapy will have consequences on urinary function, and we need to adjust in accordance to the expectations of the patient. It's somewhat rare that only urinary symptoms will dictate treatment. If a patient is 82 years old and has a lot of urinary issues, then for sure the patient is not a candidate for surgery, because then we're sure that we'll have poor outcomes for both cancer treatment and functional outcomes. Preserving erections is also part of all conversations and decision making before picking a treatment. This can help us guide in the choice of treatment. I like to remind the patient that the first and foremost priority is to treat the cancer. This doesn't mean that we sacrifice erections entirely, but once we've determined how aggressive the cancer is, we can pick in accordance with the patient expectations. What kind of medical follow-up will unfold after treatment? Well, from the moment where we get a diagnosis, where there's disease management or treatment, we basically sign a contract for about 10 years with the physicians taking on our care. Initially, follow-up occurs every 3 to 6 months. It depends on the type of disease and the surgery context. But we can think that up to 5 years, follow-up visits will happen at least. Early on, every 3 months, then we space them out to 6 months, then 12 months, and eventually land with yearly follow-ups. It depends on how well the patient recovers, if there's side effects. When we have medical care, this covers cancer care, making sure that there's no recurrence. We do that with blood work. What hints at a prostate cancer diagnosis initially are elevated PSA levels in the blood. After treatment, PSA should be null or very close to null. Any rising back up of PSA can be detected easily, and this helps us in warning us about a potential recurrence. The medical follow-up is based on both the cancer care aspect, but also the functional care aspect, especially right after treatment. We want to make sure that the patient is recovering well. We want to be present if there's anything we can recommend, whether for managing erections or managing incontinence. Sometimes we advise people to see a physical therapist, so follow-ups will be more frequent right after treatment. But the more things stabilize, the more we are going to space out medical follow-ups until we get to seeing the patient once a year. Using PSA levels is a controversial matter when it comes to prostate cancer screening specifically. You may have read up all about it before you received a prostate cancer diagnosis. However, once a diagnosis is made, PSA is exceptionally useful. Very few cancers can rely on a blood test that is as useful as this one for post-treatment follow-up. I mentioned that PSA should fall to 0 post-treatment, especially post-surgery. If there's a small change in PSA, it means that some cells are multiplying within the body. So the whole controversy about using this test for screening does not apply for post-treatment follow-up. Quite the opposite. Many people are envious in the oncology community because few markers are as accurate as PSA to know what's going on post-treatment. We're interested in two things: the absolute PSA value and also the rate at which it is increasing. The higher the rate, the more worried we get. When PSA increases, it means that cells are multiplying. We refer to this as the doubling time for PSA. This helps us to know when we may want to carry out additional treatment. It is not rare to see PSA levels that are not at 0, but they're still very low and are stable. Patients may get worried to see PSA levels going from 0.05 to 0.07. However, these changes are marginal. They're nothing but a background speckle, and they do not carry clinical significance. We do try to reassure patients if PSA levels remain low. Here's a diagram illustrating what I just explained. On the left side, we see what happens after radical prostatectomy. First, there's a diagnosis, at which time PSA levels is, say, around 10. Then we carry out radical prostatectomy. This is PR on the diagram, and we see PSA fall to 0. There can be a biochemical recurrence. This is when PSA levels are then going back up above 0.2. This is a bit of an awkward situation as a clinician because this blood test, again, is extremely accurate, much more precise than any scanner or imaging test. So sometimes we have blood test results that are abnormal, but the patient is doing well. There is no evidence of disease, no evidence on scanner, bone scans, anything like that. We do have significant perspective about prostate cancer, and we know when to intervene and when there is a benefit for any add-on treatment or an adjuvant treatment. It's very rare if PSA levels are below 0.2 that it will be necessary to carry out additional treatment. Now, if PSA levels are increasing fast, then this may signal a recurrence. If there's a local recurrence, this means that there are prostate cells that are multiplying where the prostate used to be. We might also detect remote recurrence, in other words, metastases. Of course, disease management will depend on which case it is. On the right side, you can see what happens when we do radiotherapy. With radiotherapy, with or without hormonal treatment, PSA levels will significantly reduce. I mentioned a hypothetical PSA level at 10 at the time of diagnosis, let's say. With radiotherapy, PSA levels may fall back to 0.8. Now, why never 0? Well, when we carry out radiotherapy, we are not destroying all prostate cells, so there will always be a few cells left behind that are secreting PSA. How do we define a recurrence? Well, this is well documented, and we have a lot of perspective with the disease. A recurrence is defined as the PSA changing from the nadir, this is the lowest level recorded, plus 2. In other words, if the lowest level recorded was 0.8, then if PSA levels reach 2.8, this is where we're worried about recurrence. Otherwise, we simply consider some prostate cells to be left behind and still secreting PSA. There are several elements to take into account when choosing treatment for prostate cancer. First, we're not going to treat all patients. Sometimes we carry out watchful waiting and we're not going to go for curative treatment. Curative meaning curing the cancer. We're simply watching, waiting, and if the cancer progresses significantly, we'll try to slow it down. In some cases, we decide to not treat the cancer at all. We may decide to not treat the patient initially. We're delaying the treatment phase. We also have to know that we can cure a localized prostate cancer if it is detected early enough. When cancer is still localized, when there are no metastases, there's a good likelihood of curing the cancer either with surgery or radiotherapy. Of course, we always adjust depending on each patient's conditions. Treatment can have consequences on urinary, erectile, or even intestinal functions, especially with regards to radiotherapy. Some patients have very little side effects and go back to a very nice quality of life. When we start treatment, or when we move on to a more active treatment phase, it's important for clinicians to communicate well what can happen and what will happen. Once people are adequately prepared, oftentimes they can better live with small inconveniences. Yes, there will be changes on your sex life, on your urinary function, but life is not over, far from it. One's sex life, especially, is not systematically unfulfilling post-treatment. Your sex life will be different, however, and that's an important thing to integrate properly. There are various ways to prevent complications. First and foremost, a good pre-surgery education is crucial. Then, in the subsequent management of any issues with incontinence or erectile dysfunction, there are various ways to deal with this to maintain adequate quality of life for our patients. There are effective treatments for each of these issues. The idea is to see what are the main areas of concern of the patient and how interested and motivated are they to recover, say, their sexual function, urinary function, or continence. Sure, everyone wants to recover that to a degree, but not everyone is motivated enough to get, for instance, additional surgeries. But there are things we can do at any rate. The objective, of course, is to control the disease with the least possible impact on the patient's quality of life. Let's wrap it up with 3 common questions. Doctor, what treatment would you pick if you were in my shoes? Well, what I was answer to that is that the question is irrelevant because I am not in your shoes. I try to adjust according to people's wishes, depending on the situation, the context, their health. Everyone differs. This is a good opportunity to say what worked well for Uncle Jack is not necessarily what will work well for Uncle John. Their circumstances are different. The cancer itself is different. We really need to understand that it's not the clinician's choice that is being imposed on people. It's rather, I suggest what I think is better for them. One very common concern that people have is to wonder whether they will systematically wear adult briefs for continence post-treatment, whether with surgery or radiotherapy. It's quite rare that people need to wear such continence protection permanently. Some people will use liners out of safety, but thankfully, the vast majority of people have little urinary losses sometime after treatment, and they are able to maintain a very adequate quality of life. And last question, must I bid farewell to my sex life? No, not at all. It really depends on what your sex life looks like before treatment. Again, with either surgery or radiotherapy, your sex life will change, but it will not be unfulfilling. I think people need to have realistic expectations, and when we're well prepared, we're typically not disappointed. When I talk about a fulfilling sex life here, I'm referring to a couple. It's important to integrate one's partner in this conversation so that everyone involved has realistic expectations. We need to reduce performance anxiety as much as possible, and a couple who's well prepared typically recovers very well. Thank you so much for tuning in. I hope this webinar was useful and will help you to make sound decisions about your health. On screen, you see PROCURE's helpline number. You are attending a PROCURE webinar, so you may know about the website, but please don't forget this helpline. It is free of charge, accessible every day of the week. It is there to help you get objective information. Any and all questions are welcome. We have experience with all kinds of inquiries related to prostate cancer, so please feel free to use the helpline. We also again have the webinar series and the website. These are resources meant specifically for you. Thank you so much.
We warmly thank our experts and our partners for making this webinar possible. To find out more about the tools and resources available to you, or to make a donation, visit procure.ca. Thank you for your support.